7 o'clock, we're going to get started. I'm Phil Mitchell. We're going to get the Fellows webinar going tonight. This webinar is Acetabulum, Radiology of the Acetabulum and Fracture Types. So I'm Phil Mitchell. I'm out of Vanderbilt, Nashville, Tennessee. We've got two phenomenal faculty tonight, Connor Cleveno at Harborview, and then Steve Warner at UT Houston, who are joining us and have some tremendous cases to go through, and really excited to spend the evening with them. So AO North America is dedicated to education, musculoskeletal and fracture care. We don't endorse any specific product. You'll see a number of different products, but none of us are conflicted in that way. So all microphones have been muted. If you have questions, go through the Q&A box, and then the chat box is for us. So use Q&A for questions. We want your questions. Please send them in and we'll answer them live if indicated. The learning objectives, first to identify some of the radiographic representations of the acetabulum and then correlate it to the osseous anatomy. We're going to look at some characteristic cases and some of the disruptions and displacements of both elementary and associated fracture types with CT scan, and then supplement the preoperative planning with the reconstructions to finalize and then plan your case. So we're starting at 8 o'clock. We're going to review some radiographic landmarks for about 5 minutes, and then we're diving right into cases. Again, this is the Fellows webinar series. There's also the trauma series, and those are listed here. So Emile Letournel is the forefather of acetabular surgery. In my estimation, he's made four major contributions. First, the classification of the acetabulum to acetabular fractures. Secondly, the anatomy. Third, imaging. And then fourth, approaches. So for classification, for those who are not familiar with elementary and associated types, this is going to be a confusing but interesting webinar for you. But Letournel took the 10 types of acetabular fractures, and the practicality, the enduring nature of this classification system is really what is remarkable. And so he also took the acetabulum and further defined the anatomy into columns and walls, and then looked at the imaging and created and understood and used the Judet films to supplement the understanding of the acetabulum. So those are shown here, and we'll see plenty of those tonight. For those that haven't read his book, I'd encourage you to read at least the first 50 pages or so, which can really set the scene. I think this quote really sums up what tonight's all about. Treatment should not be commenced until a full understanding is achieved, and most important, during the consequent well-planned operation, the surgeon will know what to expect and not have to try and analyze the fracture during the procedure. And so this is just preoperative planning. And so tonight, our goal is that you can look at your radiology, at your x-rays, at your CT scan, at your surface renderings, and not have to try to analyze the fracture during the procedure, that you know what you're walking into. And so the first step in that is to assess your plain film. And the first step often is to cover up the injured extremity and just to assess the quality of the image. Is it midline? Is the symphysis over the midline of the sacrum? Where are the spinous processes sitting on this image? Are the SI joints injured? You can see that on your plain film as well. You can look at the ASIS and AIS and assess their integrity, and then you can look at your iliac crest. The lines are critical to assessing your acetabular fracture, and we'll talk about those tonight. You'll hear the mention a fair amount. The iliopectineal line representing the anterior column, ilioischial, the posterior column, your acetabular teardrop, your sourceal or roof, your anterior wall, and your posterior wall. Really, our goal is that you can look at an x-ray like this and in your mind's eye, begin to formulate and understand that this two-dimensional image is more of a three-dimensional structure, and which pieces are where and which displacement patterns are characteristic for each acetabular type. And then finally, don't forget about the soft tissues. We're going to talk mostly about x-rays and fracture reductions and assessing your acetabulum tonight. But a CT scan like this, your eye may be drawn to the fracture, but really it should be drawn to the soft tissues and the underlying Morel-Lavallee lesion that you're going to encounter as you do your lateral window. Or in this protrusio case, the overlying abdominal contents over the AIS that may limit your ability to put a screw through that. You may see soft tissue interposition that may direct your approach. You may have hernias that may prevent you from putting in certain screws. And then you may have aberrant anatomy, like this pelvic kidney. So we're going to start with posterior lesions. And so first we're going to start with posterior walls. And so as we go through the cases of posterior walls, look at the lines and understand the lines on all views. We're going to go through a number of important details about each posterior wall case that then have direct consequences and implications for fixation. And then we'll go through a transverse posterior wall case or two as well, and talk about what radiographic factors determine how you're going to access, how you're going to clamp, how you're going to reduce, and how you're going to fix. So this is a bit of a trail of tears. I'll go back to this plain film. If you look, it's a posterior wall acetabular fracture on the left side. You can see it's a fairly comminuted injury based on the surface rendering, and there's a piece of articular cartilage chondrocancellous fragment in the joint. And so this was a case referred to me. This was the intraoperative fluoroscopy. And these appear to be okay plates. They appear to be safe screws that seem to be out of the joint. I've seen x-rays like this with successful treatment, but unfortunately, this is the post-operative film in the PACU. And so if you look at the surface renderings afterward, you see that the operating surgeon didn't identify this critical piece of bone in the superior cranial anterior aspect of the acetabulum. So our hope is at the end of this uh, webinar, you can look at a case like this and immediately recognize that those plates were not going to work. We're in the wrong position for this particular variant. So we're going to get started. This is a case of mine, an 18-year-old male. He came in with this right-sided acetabular fracture dislocation. So he was closed reduced in the emergency department. And, these are his x-rays. So Steve, um, talk me through how you're evaluating this x-ray, how you're expecting fellows to evaluate an x-ray like this.
Yeah, I think first step is just to assess the quality of the X-ray, determine if the beam is located appropriately relative to the pelvis, if there's any rotation of the pelvis relative to the beam. And this overall looks like a fairly good AP pelvis, especially in a trauma patient. And I think you just want to be systematic with how you look at all those lines that you mentioned, as well as the other features of the pelvis, and be systematic about it. And often noting patients who have an uninjured side that you compare to, and that symmetry of anatomy can be a very useful tool in the pelvis. With an uninjured side, you can then look for subtle changes on the injured side once you start to analyze all those different lines. And so specifically with this case, you can see that the ilioischial lines are all intact. The source seal is intact. You can see the teardrop is intact. Anterior wall looks good, and you can see that comminuted posterior wall. And then I think another kind of subtle clue of something aberrant here is you can see the femoral head relative to the dome, relative to the source seal, is not quite congruent. And again, using kind of cheating, using the other normal side, you can see a nice congruent femoral head underneath the acetabulum. You can see how that right side is not quite congruent.
I'm going to go back because that's such a subtle but important finding that you can pick up there. So I think identifying the walls on a plain film can be challenging, at least if you're not looking for them. And so, like you mentioned, looking at the other side can be so helpful to see, where we can see the anterior wall and we can see the posterior wall, and then compare to the injured side to see what's fractured, what's involved. Connor, anything to add here as I run through the CT scan, both to the X-ray, and then I'm curious about your assessment of the CT. Now that we've seen a plain film with a comminuted posterior wall, what are you looking for on your CT scan? What are you noticing here that's going to decide what you're going to do?
Yeah, first a comment on the X-rays. I would advise anyone who's still trying to get better, like all of us are, particularly those in training. Most centers, or at least they should, have a trauma AP pelvis. And so even if you're got a patient with a plateau fracture or pilon fractures, just spend a minute to just look at their AP pelvis, because that just builds your denominator. And the more hundreds and hundreds of denominator images training in your brain and conditioning your brain looking at a normal pelvic x-ray, then you will be much better at seeing aberrations, seeing subtle findings of pathology. So just take 30 seconds to look at the AP pelvis. Even though there may not be an injury, there's no diagnosis, just build your denominator. And it makes you a much better detective in finding something and understanding the differences and finding subtle injuries that occur when you do have something that comes up. In terms of the CAT scan, so I'm looking through here. I'm looking at the most cranial aspect of the pieces. I'm looking how many pieces there are. Comminuted walls are much more difficult to treat in terms of their prognosis. I'm looking for any intra-articular fragments, particularly if there was a dislocation and reductions. A lot of times you can drag fragments back in during the reduction. I'm looking for any impaction. Usually it's seen caudal in the joint. So is the main thing. And then after that, obviously soft tissue windows as well.
Okay, excellent. So here's the surface rendering. Steve, are you using these or surface renderings? Are they a part of your preoperative planning? And then when do they fall into your planning? Beginning, end?
Yeah, typically the end. I think the AP pelvis is extremely valuable as an initial tool to be able to recognize the injury. And then the different three sequences of the CT are helpful to get a better idea of the osseous components of the injury, as well as the finer detail of the soft tissue. And then I think by that point, you have somewhat of an idea in your head of what you'll be looking at. But I think the 3Ds can help tie a lot of those together. I think relying too much on the 3Ds can be a little bit misleading, as these are made by averaging pixels. And so some subtle fracture lines can be smoothened. On the three-dimensional images, it may not be apparent. So I think relying too much on these can be dangerous, but I think they're definitely a extremely useful tool to look for different clamp application trajectories that you may want to be doing, as well as implant positions. So in this case, once you're applying your implants, you want to be thinking about where to apply your posterior plates and trying to make sure that those plates are positioned appropriately on the posterior wall to avoid that kind of mistake that you saw earlier where the plates maybe weren't positioned on those wall pieces appropriately. So you can start to plan in your head on this iliac oblique here, where ideally you'd want to have those plates set so that when you're doing the surgery intraoperatively, you can come to that fluoroscopic view and kind of see your plates in that optimal position along the posterior wall area.
Yeah, I think like you mentioned on that initial film where there was that subtle incongruity, the hip joint, that is an incredible amount of value too. If during the case you see that resolve as you fix and recreate anatomy, whereas if you rely only on the surface renderings, you wouldn't have access to that information, and then you wouldn't be looking for it in the case either. So anything to add, Connor, with what the information that you've been given, what are you asking for? Is this a fix? You fixing this?
I would expect to fix this. Yeah, it just looks like there's enough of the wall. I would try to figure out a way for somebody else to have to fix it because comminuted walls I just find them to be challenging. I mean, you can do them, but it just seems they're less satisfying and the rates of post-traumatic arthritis are higher.
Nice. So here's the post-op X-ray on this patient. He had a wall that was of reasonable size, so we fixed it with a single recon style plate. And I just want to point out here again two different iliac obliques on the left side. So here was the one that was shot maybe right after, and then here's another one in follow-up. And you should be able to look at the other side and know where your wall is, and then know that your plate is where you expect it to be. Coming back to that disaster case, if you know where it's supposed to be to hold and fix, then you can predict on your iliac oblique where it will be. So look at those. To your point, Connor, get lots of reps looking at the uninjured side, knowing where the posterior wall and anterior wall begin to overlap and what each morphology looks like. So
I think, can you go back there, Phil, just to your AP image? Yeah, so this is do you have a fluoro AP? I can't remember.
no.
No, it's okay. So one thing I see people mess up is look how perfectly positioned that plate is, nice and lateral, just medial to that posterior rim line on the AP. And if you go to the obturator oblique, then it's a totally different projection. And people don't get a good AP fluoroscopically intraoperatively. There's something that's slightly an obturator, and so the plate looks more lateral than it actually is. And they don't notice that, and the plate ends up being too medial. So when you're intraoperatively, you're getting your fluoro shots, getting your obliques, Jude views, make sure when you get your AP and you're really evaluating that plate position that it's a proper AP, that the obturator foramen is symmetric, that you have a plumb line down the sacrum to the symphysis. Because I think you can see on that obturator oblique just how lateral that plate looks. And I think what people do is they get a slightly obturator oblique instead of a true AP, and they get fooled that their plate is nice and lateral, but it really isn't.
Yeah, along those lines, I think one thing that also helps with that is on the iliac oblique, kind of looking at the distance between the AIS and the greater orthotic notch, and that gives you a sense based upon the three-dimensional image of where you want that plate to be. And then you get that fluoroscopic view here, and you can see how far anterior, how far lateral that plate is over that wall. So I think that view is also just to augment all these different kind of discussions of the different views. This view can also be really helpful to see how far you want to kind of swing that plate out laterally over the peripheral wall.
Nice. All right, Steve, this is a case of yours, so slightly different. Contrast that last case to this one. You've got a reduction film, a pre and a post.
Yeah, so always concerning when you have X-ray of the pelvis labeled as a post reduction with the hip dislocated. It means that there's probably something obstructing the reduction. And so, as we saw in that last case, a very subtle incongruent to hip joint for that posterior wall fracture. This one with really inability to put the head underneath the dome, which is obviously our goal with reducing a hip dislocation. So what do you guys think? If you guys see this, what are your thoughts with the post-reduction or traction X-ray like this, with the femoral head being still unable to be reduced under the dome?
Well, I'm curious about what's preventing it, So I think this is where the post reduction CT could be helpful to get some more information about the pieces. The second thing I'm wondering is like what time it is, um, because if this is the post-production film, I don't want to leave this like in this position for very long. So I'm wondering what time it is, what the access is going to be to get to the operating room, because I don't want to leave the hip like this. But I think more information, like the CT scan, would be helpful to characterize what's in there. What do you think, Connor?
Yeah, definitely agree with that. The challenge sometimes is if this is in traction and then they go to the CT scan and it dislocates again. But I agree with you. I think I see several fragments in there that would easily explain why that's so laterally subluxated. And you could imagine the fragmentary wall there as the reduction maneuver happens, it just the femoral head drags the pieces back in there and prevents the joint from being concentric.
We seem to have a lot more of these in July for some reason. I don't really know why, but yeah. So Steve, tell me about like your assessment of this debris, because debris isn't debris. What do you think when you saw this reduction CT? I guess it's like incomplete reduction CT, but
Yeah, so I think it gives you really great information about the sizes of the posterior wall fragments, how many fragments they are, as well as the location of the fragments. I think it gives you a sense, is this something that may be amenable to some sort of percutaneous procedure that may give you an opportunity, depending on the patient's physiologic status, time of day, anything like that, that may give you opportunity for a relatively short procedure that could get the head under the dome and then come back to do a more extensive definitive surgery. Or in this case, with multi-fragmentary wall where the pieces are kind of more anterior as opposed to more cranial, potentially less successful with the maneuver of a percutaneous type of procedure.
This also shows you like there's free pieces, like free osteochondral pieces that can be in the joint in the cotyloid fossa. This has the lateral wall that likely has maybe some of the labrum on it. When that flips anterior, that can be very difficult to unflip. And you look at the 3Ds and be like, oh, I'll just flip it back in. But it's not so easy, particularly if it's a muscular patient, which this does look like one based on the soft tissue windows. So that can definitely be challenging. To be ready for that if the actual wall attached to the labrum and capsule gets flipped anterior to the head, that can be a very challenging situation to get that unflipped back to its native location.
for sure. Steve, talk about this image, the initial shot in the OR prone or lateral, but why a shot before you even get started here?
Yeah, I think it serves multiple purposes. I think the first thing is um, can we see those fragments that are preventing a congruent reduction with fluoroscopy? Sometimes you can, sometimes you can't. So I think based upon the CT that we have some sense of where they are, how big they are. And so can we use fluoroscopy to help correlate that? Whereas once we think we have the head reduced and the posterior wall fixed, can we ensure that we have removed all those pieces that were initially there? I think that's one big reason. The other reason is I think anytime you reposition a patient with an unstable acetabular pelvic ring injury, you just want to ensure that you have the position of the hip, for example, where you think it is before you start your approach, because sometimes patients will have a redislocation or some other change in their hip position just from even just from induction of anesthesia or repositioning them.
Yeah, I think such an important point. This is a large piece, so we'll see this on fluoro, but there are some that are really small. And if you can see it, then you can know when you've achieved your goal of retrieving it. But if you can't see it, then you know that pre, and you that may be where your measurements come into play. And you say, well, I'm looking for a 2x1 piece of chondrocancellous uh, material, you know? So looks like you all put on a distractor to get this. Then was this a prone distractor case?
Yeah, prone distractor just to be able to retrieve all those pieces. And I think your point, Phil, about the size of the piece, kind of that 2x1 measurement. So, especially with a multi-fragmentary wall, I think it can be very easy to miscount a piece or grab a part of the piece and not the whole piece. And so, accounting for the number of pieces as well as the size of the pieces based upon the preoperative imaging can be critical just to ensure that once you have the hip reduced, that you've had all the pieces accounted for and haven't left anything behind.
For sure. Included these two images as well. Maybe talk about safety of screws, intra-op, how you're assessing, what views you're using.
Yeah, so I think especially for that cranial screw, just to ensure that you're cranial to the dome of the acetabulum, getting a obturator oblique fluoroscopic view, which is going to be if you're in the prone position, kind of rolling the C-arm away from you. And so it still gives you the opportunity to get a fluoro shot with the C-arm out of the way. And then that gives you a really nice view of the screw trajectory being just cranial to the dome of the acetabulum to ensure that you're not intra-articular with your fixation.
For sure. I think these show good, excellent reduction and good images to show that on that obturator oblique, we can see the cranial screws are out. On the iliac oblique, that's where you can assess your caudal screws and show that they're out of the joint as well. So a beautiful CT scan. I think on these, in terms of assessing the CT, one of the most important things that I'd be looking for is success in retrieving all of the individual fragments that you saw on the pre-reduction CT, and that looks like y'all achieved that goal really nicely. Post-reduction, excellent follow-up at a year. So, Connor, this is a case of yours, a little bit of a different case than that last one. Maybe talk us through this one, this dislocation film, and this closed reduction view.
Yeah, if you look back at the previous image, you see that sort of more triangular cranial piece, and that gives you a hint that this wall may be extending a bit more anterior than a typical one. So maybe the hip wasn't as flexed when the impaction happened. And so then if you go to the next view, you kind of see that how large that piece is, as well as it's sort of, we have sort of almost a teardrop view there, we're lacking a bit of outlet, but you can see how there's disruption into that line. And so that starts to clue you into the fact that this wall may be much larger in its extent anterior than a classic posterior wall. And that happens just because classically the hip is flexed more. And so the fracture lines will be a bit lower, but as the hip is extended as the impaction, you may have the extent of the wall extend more anteriorly, and that actually goes to the actual overall femoral head stability. So you may, in some sort of extreme situation, you can't even hold the head in there until you reduce the posterior wall segment. So this is to me, I see this, and it's a different animal than a typical, dashboard injury often. So.
For sure.
And then so I
So
carefully look through the axial CTs, and you can kind of one, it's multifragmentary, but you see just how much of the weight-bearing dome is involved here relative to a typical wall. So clearly an unstable pattern, and the significance of that is substantial given, if you can't get this reduced and held, then their conversion to post-traumatic arthritis is within months.
for sure. So how are you deciding with something like this to include additional changing your position, additional maneuvers, osteotomies to get access to that area? What views are you using to know that
Yeah.
you need to do that?
That's a great question. I would say I combine both the axials, and I find these 3Ds really helpful for this, is just seeing how you get a sense of how far anterior the wall extends, sort of anterior to the pillar there. And a couple of things. So for me, this is one where on my calculus here is a consideration for an osteotomy just to help my exposure anteriorly. Is it mandatory? No, but I do find that the way that we've learned to do osteotomies, the risk is very low for non-union. And it can be just a simple osteotomy that you can gently retract the abductors as opposed to just cranking on them harder to see anteriorly. And so I find that if you do a simple controlled osteotomy, I see the abductors look better at the end than if I'm just sort of having somebody crank harder to get that extended visualization anteriorly. The other thing I'll say is I think there's a tendency for people to think that they need two screws anterior to the fracture. And that is if you have a simple pattern, no one's going to argue if you have two screws in your plate that extend beyond your fracture. But there's actually no reason to, particularly as these fractures get more anterior. A screw through the fracture at its cranial extent is incredibly stabilizing for that. So don't think you need to keep pulling on these abductors, keep damaging these abductors to try to get some plate that extends all the way to the AIIS. So, even if you have one screw that extends into the fracture and then your second screw goes through the fracture, that's sufficient. I've had pretty much everything fail in the book that's possible, but I've never seen screws pull out of the ilium crania. The bite there is excellent, and so that's usually not the issue. It's usually an issue of did the wall fall apart or did you not place your implants appropriately? It's not because you didn't get screws that had enough purchase. So in this one with that very anterior extension, I elected to go lateral. And that allowed me to use more of a sort of the optimal extent of the osteotomy. It's a digastric osteotomy. We put a step cut in there, so there's inherent stability to it. And then you have a much easier ability to just gently retract the abductors anterior and visualize and clean that fracture as it extends anteriorly. We added some mini fragment screws into the piece just as if you would be fixing a plateau or any other periarticular injury. And then you can see just how nice and lateral that lateral plate is, and then a secondary plate given the size of the wall.
Excellent. Steve, anything to add with that? Anything you're doing differently for these very, very anterior cranial extent walls?
Yeah, no, this is a great way to access kind of more anteriorly through a posterior approach. I think another method that can be used is just with gluteus minimus debridement, which is often, especially in this case, will be heavily traumatized by the injury and a potential risk for heterotopic ossification. So I think debriding some of that devitalized muscle can really help with the anterior exposure up to the level of the superior gluteal neurovascular bundle.
Awesome. Next case, 66-year-old. She was 11 days at an outside hospital and had this plain film when she came in. I think I use this as a great example for our residents to show that this could be pretty easy to not see that the hip is actually subluxated on the left side and that it's not under the dome and that's actually out the back and that it's been sitting that way for 11 days. And so this was her CT scan. And so Connor, talk to me about what you're seeing on this one.
Yeah, so first of all, great point on the X-ray. The emergency medicine residents will miss that. You, as the orthopedics, hopefully build in that denominator, will see that right away. I see a massive amount of impaction Not surprising since she's been sitting like that for days, and particularly in that age group, the bone just melts away. I see multi-fragmentary walls, so really, really challenging prognosis for an ORIF in this age group with this amount. You can see just how flattened that posterior kind of facet of the joint from the impaction right there. That image on the right is perfect.
Yeah, I find the axials are helpful, but don't forget about your coronals and sagittals. Sometimes they can also give you some information. And so you can see here more details about the impaction as you're assessing it. And sometimes it'll be like this, like little potato chips, little Lay's potato chips of cartilage that are in there. But then sometimes it may be bigger pieces that you can only see on your sagittal view. So look through all of these, your views as you're assessing for your posterior wall, to know where the impaction is, how big is that piece, get your chips ready or what have you. So with this character of the impaction, you can see the how thin that is. We elected to fix and replace for this particular patient. But again, just an example as you go through these different features that may dictate treatment. So one more posterior wall,
So
37-year-old.
one
Yeah.
quick thing on that impaction, I think two other things to keep in mind, especially in a 66-year-old with kind of a subacute area of impaction and dislocation, is always looking at the femoral head too. The femoral head can often be impacted and have a big impact on their clinical outcome. And I think the other thing is to keep in mind is not just the articular impaction, but also the cortical impaction, which can happen, especially in these delayed settings. And that can, if you're using that cortex on the intact ilium to guide your posterior wall reduction, a lot of times that can be deceiving or not a great articular or not a great cortical read to guide your articular reduction. So I think that's important that you can keep that in mind when you're looking at these axial or any of the CT images. Look for that cortical impaction from the femoral head resting on the intact posterior ilium, which I think can kind of be deceptive when you're reducing your wall.
Very disorienting. Why isn't it reducing? Everything looks good except for this one spot. So yeah, if you're not looking for it, it can cause you troubles and cause the case to double in time. All right, next one, 37-year-old male. This is his AP pelvis. Here is his CT scan. So the injury's on the right side. We see a caudal comminuted wall. Run through that one more time in terms of its relation to the dome. No
And
history of dislocation
can you
in this
show the
patient.
AP X-ray one more time too?
Mm-hmm.
Okay, thanks.
Here's the AP. There's our CT, and then there's our surface rendering. So, uh, Connor, how are you thinking about this case? What are you looking at on the AP?
When I'm
What
look,
do you see?
yeah, so this is this interesting case. I look at the AP and I actually look at this view too. Look how much of the femoral head's uncovered here. And then if you look at the AP, I'm not a dysplasia person, but you can look at things for the center edge angle, you look for crossover signs because people have looked up and evaluated size of the posterior wall, location of the posterior wall, but it's the overall hip. So I don't think anyone's really convinced me anything but the gold standard of doing an EUA, unless something is like, completely tiny or non-displaced. But I think the gold standard for me with these intermediate patterns is still to do a stress examination under anesthesia to evaluate for any subluxation of the femoral head because it's a three-dimensional structure. It has to do with the size and location of the wall fracture, obviously, but it also has to do with the version and coverage of the acetabulum, the version of the femoral head or femoral neck. So it's everything together that, and we don't yet have an AI program to give us that answer yet. I'm sure we will. But as of today, I mean, I'm still taking these to the operating room to do an EUA and to look to see if there's any dynamic instability.
Steve, would you be surprised if this was unstable, or is it kind of a 50-50? How good are you at predicting? And there are certain features that you're looking at to say, well, this piece is more displaced. I can see where the head went. Is that more of a predictor for you? What are you looking at?
Yeah, I think I'm not. The short answer is no. I'm not good at guessing which ones are going to be unstable. I've been fooled a lot of times, and ones that I thought would for sure be positive and are not, and vice versa. So I think there is a lot of value to the EUA. On patients who have other injuries that also have a small posterior wall that you're like, for sure, this is not going to be operative, but the patients go in the operating room, so let's do an EUA, and then they're of course unstable, and so I think they're really kind of useful exams. But I think in this particular case, even though the clinical history did not show it or did not have a dislocation event, you can see by the details of the imaging on the CT on those axial images, there's a osteochondral fragment inside the joint. There's some air densities anterior to the joint. The posterior wall is displaced and comminuted. So I think all those features are highly suggestive of some sort of dislocation event that happened, and maybe it was spontaneously reduced at the time of the accident. But I think the imaging is highly suggestive of a dislocation. So I think based upon the intra-articular fragment, the air densities anteriorly, the comminution displaced in the posterior wall, I think this definitely deserves an EUA to assess stability.
Yeah, so here's his EUA flexed up, and you can see with some light pressure, not too much, but just enough. We see subluxation of the hip. And so is this a positive EUA for both you guys?
Yeah, for me, definitely. I'm not trying to go in there and do some, jujitsu dislocation event. I'm just trying to elicit for any subluxation. And so I start with gravity in the most provocative position and then, add a little axial stress. So you're not trying to dislocate a hip. You're trying to see if under sort of natural physiologic motion, you're going to see subluxation because the natural history of this, if left unfixed, is arthrosis within months. And once every few years, we kind of see it, the small wall that was left undone, and then we get it referred to us. And literally within 6 to 8 weeks, you'll see changes because of the instability. Joint instability leads to arthrosis exponentially quicker than just a step off in a joint reduction.
Yeah. So here's our fix following the EUA.
And
And
then
so
Phil,
again,
there was a question that came through
yep.
about when to use spring plates. So I'll kind of toss that to you and Steve. When do the spring plates happen?
Yeah, so I think it is based on size. I showed that first case that had a big enough wall, maybe with some other bits of comminution where we felt that we could achieve stability with that recon plate. I'll say a really helpful technique. Let's say you put on your recon plate is to stress your wall, to take a dental pick to try to dislodge your wall from underneath your recon plate. If you can dislodge it, then you just take the recon plate off, put a spring hook on, and then put your recon back on. So I don't know, Steve, would you have used a spring hook for this one?
Yeah, I think it's a great example of one that I think would benefit from a spring hook. I think you have to think about, if the recon plate is positioned as kind of far peripheral as you can without being over the labrum, if that's going to be appropriately balanced on that piece to provide stability. And I think that's be challenging in this case to do that. So I think a spring hook gives you direct fixation on that piece that provides excellent stability. And you can see that, the recon plate is supporting that spring hook plate very nicely. And I think that iliac oblique image that you have there really kind of shows that how you have that recon plate over the periphery of the spring hook plate to kind of support those tines that are sitting on that wall piece.
In some patients, if they're thin enough, like this patient, we can see the wall on the iliac oblique in the OR, know that the plate's where it needs to be. So here's some more examples of just the different amounts of iliac oblique, the different amount of roll, and where the walls sit. So pay really close attention because again, this is the same patient, same plate, just with the different amount of iliac oblique. So you should be able to recognize that. So this ends the posterior wall segment. I hope at the end of this, we've demonstrated all of these numerous components of the wall that can impact your fixation and can dictate successful treatment. Size, extent, debris in the joint, impaction, instability, all important and all which result in a slightly different method of fixation or a different treatment entirely. So we're going to move on to a few transverse patterns. This is a patient, she's 36, she's 275 pounds, isolated injury. That was her injury film, so it's an okay AP pelvis, but we see there's some sort of hip fracture dislocation. Reduction and traction was attempted up to 40 pounds, eventually offloading the head. It's a totally different discussion about what to do, what's the limit of traction. What do you do at this point? You know, Saturday morning, the non-pelvis guy's on call. What are you going to do? He's calling you. But we're going to talk more about the morphology of this particular transverse. So I'm going to run through the axials, and Connor, maybe you can start telling us what you see here.
Yeah, first of all, I'd classify this as a transtectal, which is incredibly important for, you have to get this reduced accurately. These ones have a, high and quick rate of post-traumatic arthritis, particularly if you don't get them reduced soon. Like had a couple where it was sort of reduced and then traction was taken off, and by Monday morning when I came to fix it, there was a giant divot in the femoral head. So these are really critical to treat early with a proper closed reduction. Make sure they're not grinding away on the intact ileum. I also see some joint fragments in the joint there, right there, and then some impaction more superiorly. I think I saw.
Excellent. Let me go to the coronals. Yeah, it's interesting. This gal, we fixed her again. It was a Saturday. The head was being loaded, and you can see that's such an important point. That edge loading right on the head, and I mean, it was probably 8 hours, and she had a dent in her head. It was really remarkable how quickly that happened. So
Yeah, I
there's that.
definitely learned the hard way where there was a reduction, and then I think traction was taken off for like an additional CT, and then nobody checked. And when I came in Monday to fix it, right there, I mean, it was like me taking a pitching wedge at the femoral head, and just the size of the divot. Just we fixed the transverse, but she went on to arthritis, within a few months.
Steve, maybe talk about the wall. You know, we just went through posterior walls, but this wall get your attention at all? Is there anything different you're picking up on the CT scan in terms of fixation, access, reduction with a wall that looks like that?
Yeah, I think most of the posterior wall fractures that people are going to be fixing are more caudal tension failures. And so that gives you some clue with a more standard wall that different techniques for reduction and fixation. This is a bit different than most of the displacement is in the cranial side. So the wall is being displaced more cranial as well as lateral. And so that's going to create different soft tissue injuries, especially around the labrum, as well as may make you think differently about what techniques you're going to use for reduction as well as fixation. And so, where we want to prioritize the more caudal fixation, the caudal tension failure walls, maybe with this one, we want to prioritize a bit of different fixation strategy.
Yeah, you can imagine the labrum is tethering down below, and there's going to be a tear right at the fracture site there. So here are the Jude films, and so those factors that both Connor and Steve mentioned are going to dictate the position, the sequence, and the fixation. So, um, Connor, what position will be the sequence for this one?
Yeah, first of all, trying to do this as soon as possible. The transverse fractures, the longer they stay displaced, the harder they are to reduce. So, some of that's just the muscle, but it's also the ligament. So the sacrospinous and sacrotuberous ligaments can shorten. If you're trying to do this at a couple weeks, it takes some time to mobilize it out. So try to jump on these as soon as you can. I'm going to go prone, posterior approach. uh, get that located, clean out the fracture from the back, take that piece out of the cotyloid fossa. The posterior wall here is atypical in that, usually the wall is hinged on an intact labral attachment, anterior cranial. In this case, it looks like it's been torn cranial. It's just unusual. The bigger the wall, the more you're going to see the head and the joint when you reflect it. And so sometimes with a large wall, it's actually easier because you can get better access to clean the transverse as it extends anteriorly. And I'm going to want lateral track, like a pin in the femur to pull lateral traction, and a clamp through the notch, and then a screw down the anterior column aspect of the transverse, and then reconstruct the posterior wall, which is, almost the entirety of the retroacetabular bone in this case.
For one thing,
Awesome.
if you go back real quick, just
Yeah.
talking about that AP pelvis image, I think is important to pick up in this patient with this pattern is, again, we talked about the soft tissues importance on the imaging, and the displacement of the bladder contrast here is not insignificant. I think consistent with hematoma, which I think with this pattern, with that apex of the transverse in the greater sciatic notch area being cognizant of that during the approach of any injury to the superior gluteal artery or vein. And so with this image here, looking at the soft tissues, I think that's an important thing that could potentially kind of change what you do intraoperatively.
Absolutely. Yeah. So, in my diagnosis for this transverse posterior wall, transtectal type, and shown there, there's debris in the joint that we measured out. There's impaction. That's the rock in the shoe that's going to keep the transverse from reducing anatomically. And so that's going to be disimpacted before you can see that right there. Small, but important. And then the wall. I think such a critical discussion about this wall. You'll look and you'll say there's debris in the joint. I'm just going to retract the wall away. This may be a different mechanism for you to be able to get in and access. It may be a different amount of force. There may be the sciatic nerve may be in your way. If this is a large patient, you may need to consider that as well. So here's the series of steps. We expose, we clamp the transverse. So coming back to the lines, as you clamp a transverse, you're looking at your lines. I'm looking at iliopectineal, I'm looking at ilioischial to make sure that they're restored. Sometimes a little bit of inlet tilt can also help that view on the left side
And you're
to show if you're
prone,
just a
right?
little bit off. Prone, yep,
You
prone.
would posterior.
Pros, prone posterior approach.
Yeah, and I think
So
that's great. People sometimes see the 3Ds and they want to go anterior first on these, and I just don't think it's necessary, unless it's some subacute, it's been a month or something like that. So
Bill, in terms of positioning the tines of your clamp, are you adjusting those based upon just the preoperative plan, imaging, or are you using anything fluoroscopically to assess where your tines are through the notch that you really can't see, but you think they're in the right spot?
So seem to put my clamp on underfloor on the majority of the time, just to know, like I'll put it in. I think the CT is so helpful to look at your axial and just to know that when you bring it down, when you tighten your clamp, where do my tines need to be? I look at this view right here. And I say, okay, based on this, where am I expecting my times to be to get just perfectly perpendicular to the fracture line? I think to Connor's point, some of it depends on how old this is too, about how long you're gonna have to fight it, how long you're gonna have to clean it, how much twisting of the clamp may need to happen. But at post injury hour 8, it's typically going to kind of click right in. I think, but yeah, I typically do it under fluoro. After I've got it in, all right, okay, I like where that tine is above. My tine isn't on the top of the femoral head. So I don't know. You have any pearls for that?
No, I think that's great. I think it's just helpful to have some idea, like you said, on the preoperative imaging, and then correlate that with the intraoperative imaging as well.
If you draw out, your fracture, like that bottom left image, for fellows who are watching, if you draw it out on your dry erase pelvis, you can take the clamp in, you can be visualizing and know exactly where your tines need to sit. So it can be super helpful. So put in the column screw, release the clamp, the transverse holds, 2 plates. Here's her 1 year follow-up to your point, Connor. I thought it was a reasonable fix, and you're starting to see some arthritis in her at a year. She's got 3 out of 10 hip pain kind of thing. So these are high risk fractures.
but if you don't get it perfect like you did, that's like a 6 week, 2 months. She's gonna have end stage arthritis. So this was awesome, and you got her, at least a year. Sometimes you can get much longer, but the transtectal fractures as perfect as you can get them if you're planning to try to save the hip.
All right, Steve, this is your case, 15-year-old ATV. Contrast that transverse that we just saw to this one. What are you seeing on the plain film that's different, that's getting your antenna up?
Yeah, I think a transverse isn't a transverse. There are lots of different patterns of transverse fractures. So I think the obliquity of the transverse is one consideration. We talk about location, whether it's transtectal juxtatectal or infratectal, which I think is one component, but also the vector of the transverse as it goes from anterior to posterior can be a factor as well for some of the treatment. And so I think that's one thing. And then I think the other thing, going back to the kind of earlier slides you had, is just being systematic with watching and looking at an AP X-ray. So I think most people's eyes are going to be drawn to that right hip and how it's dislocated and how the fracture is displaced. But as you kind of be systematic about it, you want to also look at all the different other lines and features of the pelvis and the contralateral side. So you can also see a contralateral much less displaced acetabular fracture, as well as probably also an associated pelvic ring injury, which is always important to look for as it may alter your surgical plan.
Yeah, I think for this, again, if just going back to judging the quality of the X-ray, it's not perfect, but it's close. But if you look at the ilium, you've got one side that's here, and then you've got like Mickey Mouse on the right, and so you're just seeing almost like an iliac oblique of the ilium on that side. That the antennae are going up, and then also if you look at the caudal segment on both sides, they're similar. It's not the caudal segment of the transverse isn't medialized and that can suggest that you may have a variant as well. So now your plain film to your CT scan, what are you seeing here? How are you starting to think about how you're sequencing something like this?
Yeah, so I think just looking at that axial of the SI joints, you can see a definite SI joint injury, especially on the right, but also, you're going to be assessing the left side intraoperatively as well. But I think going to kind of the transverse family of fractures, you're looking at the obliquity of that fracture and assessing how you're going to reduce that and the vector of your clamp. And sometimes, even though clamping, like you showed in that last case, is a nice go-to clamp application with more of a vertical fracture like this, as you might imagine, that obliquity may not be the best vector. So maybe you need to supplement that with another vector of a clamp to really reduce the transverse well.
Anything to add there, Connor, on this particular case, this particular pattern?
I would say this one, you have, like Steve said, you have a real SI joint injury, and so that can complicate things with this. And even back to the initial treatment with your AP pelvis, just straight traction may not get you reduced because, as you said, the ilium is substantially externally rotated. So the femoral head may not sit located until you internally rotate that ilium. So it's, because you can't bring the femoral head into, to outer space where that is sitting. So just recognizing an ipsilateral SI joint injury, and this is a significant one, can complicate the overall reduction of the transverse.
Yeah. So here you go, Steve. You all put on looks like an oblique frame
Yeah,
to.
so kind of getting to the posterior ring, just getting the intact ilium in a anatomic position to be able to help reduce the caudal portion of the transverse, I think is helpful sequence. And so it's just showing a couple of different ways to get the posterior ring right, and then you can move forward with the transverse reduction once now the intact ilium is back in space where it should be. And then I think as we move forward with the florals, we can kind of see the posterior ring fixed and then it's kind of some different vectors for clamps. So again, using the florals, kind of knowing what the three-dimensional images show, and then orienting clamps appropriately to be able to provide the vectors needed for the reduction. And sometimes it's more than one clamp to get the vectors that you need. And so I think preoperative planning, knowing that obliquity of that fracture is really important.
And it looks like you got a little 2-for-1 deal on this one. Got the other side done too. So I think a great case highlighting the importance of identifying SI joint injury above a transverse and a beautiful result. Yeah, have you seen one that they didn't recognize the SI joint? Is that bad? Like, is that bad, or have you seen that go sideways?
Uh, the, yeah, I saw one where it was just left externally rotated, and so the reduction was just never accurate. The other more comical thing I saw is like, three, four, five attempts with the resident just pulling traction to try to get the head reduced. They didn't recognize that the ilium was externally rotated. So no matter how many times they pulled or tried to pull with the towel or this or that, it was just never going to work. So.
Yeah, it's once you fix one of those like that using that technique and see how easy it is, you're almost looking for it because it's so satisfying to do to get it right that way. So, wrapping up posterior lesions, we're going to go a few minutes over. We got some really great anterior cases next, but uh, wrapping up transverse, we talked about the different types and identifying on your imaging what type it is and some of the important features in your transverse that may dictate how you're accessing, how you're cleaning, how you're clamping, how you're reducing, and how you're fixing. So, Connor, this is a case of yours. Why don't you tell us what you see on this one?
Yeah, so clearly you see a central dislocation, or the femoral head dislocated into the pelvis, and although the contrast is gone, you can see the displacement with the bladder as well. And this hopefully alerts you to a anterior based type acetabulum fracture. You can see the fracture line through the anterior column. You see the displacement through the posterior column and the pubic root, as well as fracture extending into the posterior wall aspect of this.
Nice. So here are the Jude films, and then we'll go to the axial and kind of walk us through what you're picking up now that you're starting to be in plan mode, thinking about approach, thinking about what you're going to be seeing, looking for, clamps, that kind of thing.
Yeah, so hopefully people are recognizing this as associated both column, and as I'm scrolling through the axials, I'm looking primarily what is going to reconstitute my joint. I'm finding what my spur is following that down, following my anterior column segment, following my posterior column segment, and then in this case, as is not uncommon, there's a relatively large posterior wall segment, and there's differing sort of morphologies of those and their relevance. In this one, it really is a large segment of the weight-bearing dome. So to reconstitute this joint, we really need the anterior column and the posterior wall segment, and then secondarily the posterior column. In a lot of patterns, it's the anterior column to the posterior column, or maybe it's the anterior column to the spur, the intact posterior ilium with posterior column. So, this is an associated both column. It's a relatively simple anterior column segment which extends anteriorly. Posterior column is very classic, and in this, there's a posterior wall segment that extends anteriorly, and as we saw in the axials, it involves a lot of the weight-bearing dome. So it's not one that just sort of can be secondarily ignored because it's so posterior. It is extends anterior to the pillar there and involves the weight-bearing dome. Now, these walls are different than a posterior wall fracture that we started the conversation, and it's primarily because the labrum is still attached, both cranial and caudal. So it's, if you did an EUA on this, it's not going to subluxate or dislocate posteriorly. That's not the instability pattern here. So it's not a posterior wall where the hip was flexed and the femoral head, fractured the wall posteriorly. This is a fracture line that's part of an associated pattern, so associated both column pattern. So it's definitely a different animal. And so you still are going to approach anterior. Our primary function is still getting the anterior column back accurately. And in this particular case, as we saw in the axials, the majority of reconstructing the weight-bearing dome is getting the anterior column back to the posterior wall segment.
Yeah, so you've got a really nice couple of pictures here. First showing that posterior wall and the size and that it is occupying a substantial portion of the dome. And then how you're planning even your clamp application on the axial CT. Again, it's so easy to go just to the surface renderings and think about that, but here you can even think about where your clamps, where your tines are going to be to reconstruct your dome. So, and then putting that onto the surface renderings here.
So this clamp on the left, that's a clamp from the anterior column to the posterior wall segment, and then we're looking at that, evaluating that on an obturator or oblique view. So the 3D reconstructions are so helpful for you understanding the morphology of the fracture, where you can put clamps, but intraoperatively, you're looking at fluoroscopic images and you're looking at your Jude images. So and I would say, be honest with yourself. I mean, if you want to save only the good ones for conference or something like that, that's fine. But intraoperatively, whether it's a transverse or it's a, posterior wall, try to get the worst X-ray possible in terms of the displacement, and then get your clamp on and try to get the reduction and judge yourself based on your worst X-ray. again, if for conference or whatever, make sure you save some good ones too. But intraoperatively, really be honest with yourself and evaluating, is your femoral head staying concentric under the ilium? Because all of these are about the femoral head, right? Whether it's a posterior wall or an associated both column, we've mentioned, if the femoral head is unstable, that's what leads to the arthritis. So in this view, you can see we've clamped the intercolumn to the posterior wall segment, and then we can place screws right across that to stabilize that. And then for the posterior column, as we saw in the axials, that's going to be reduced to both the anterior column as well as the intact ilium. And then we can buttress that to prevent the medialization.
On this view, Connor, are you
Yeah.
looking where are you looking to know that your clamp has delivered the result you want? Are you looking at the joint
Yeah,
here?
couple things. So you see a fracture line there that we're dialing in the reduction, and then you want to see that the femoral head is not sagging caudal. So if on some associated patterns, you'll see the femoral head is nicely within that caudal facet, like along the posterior column, but you'll see gapping cranial that's sort of like allowing the whole femoral head to displace. So on this view, I'm wanting to get those the fracture line keyed in, as well as making sure I'm bringing my head up to the anterior column.
Okay. And here we go with the final result. Beautiful X-rays. I think your point about getting a fluoro shot where it looks the worst is so important. And then having an understanding of what you're doing. So you just dialed in more inlet or outlet. What part of the joint are you looking at and thinking about that is going to help you then impart the correct reduction maneuver, addressing the impaction or whatnot. So not just getting the worst, but also how did I get that and why is going more inlet showing me that and where is that on the joint, you know? So beautiful X-rays. Can see that the clamps delivered the result you wanted there. And then nice 2 month follow-up, doing awesome.
Typical trauma patient, 2 months and gone.
All right, Steve, take us home here. 59-year-old bike accident. Judge our AP pelvis. What do you see and what are you thinking based on this X-ray?
Yeah, so I think important features on this X-ray, that right hip, you can see that femoral head is not congruent with the intact dome of the acetabulum, and it looks like the source seal has been disrupted, and there's displacement of the medial dome of the acetabulum that the head is settled into. And so, again, these are features that you can see on this injury X-ray that I think are important to restore under intraoperative fluoros, where you want that. Femoral head to be congruent with the intact dome, which means it has to be, distal and lateral to where it is now. So you can look at the, all your ilioischial, ilopectineal lines, and again restore those. His other side, as we mentioned, there's some variations in the contour of those lines, and so using the other side, having good AP pelvis and restoring those lines to the other side is really critical.
How, how are you deciding? Because this looks operative based on your medialization, based on your displacement. Sometimes they don't have that. And it's an anterior column, posterior transverse. There's some comminution, but the hip's sitting under the dome. Maybe there's not that subtle bit of incongruity. How is there an imaging way to evaluate that? Is that a part of y'all's practice to evaluate stability in that scenario?
Yeah, I think one good way to look to see if the femoral head will stay underneath the intact dome in these patterns is to get some Judet X-rays where the patient is being rolled up to be able to get those oblique pelvis X-rays, and with the different forces on the hip joint during those views, you can get a sense for if there's any instability of the hip that would then lead to the femoral head being incongruent with the intact dome.
What about you, Connor? Any pearls for those? What if they like hurt a lot? The Judaics are fine, but they're like really hurting. Can I do perk then, or what? What do you think?
You're saying percutaneously fix it if they're hurting a lot?
Yeah.
I definitely think that where I see the sort of minimally displaced are in the elderly, and I think I would treat elderly fractures different than non-elderly fractures. Same way we think of femoral neck fractures, right? It's the other side of it. So if you want, like we just showed a case where we went to arthroplasty, right, with that impaction. So I think the consideration for the elderly should be, slightly different. If that means you're doing percutaneous fixation that helps stabilize them, and you're going to let them weight bear on that, I think that's a reasonable consideration. Because what are we going to see commonly in practice? We're going to see posterior walls, and then we're going to see a bunch of elderly people falling on their side and their trochanter hitting first, and they're going to get some variations of anterior column, posterior transverse, whether or not the posterior transverse is complete or not. These are the common things you're going to see. They're low anterior columns oftentimes, or almost like an anterior wall posterior transverse with or without impaction. That's what you're going to see a lot of in practice.
Yeah. So we got 15-pound traction view. As we go through the CT, Steve, what are you looking at in terms of deciding what's next steps,
Yeah.
approach wise, and things like that?
Yeah, see the displacement of the dome there. You can see how displaced the dome of the acetabulum is, as well as the impaction. You can see how the femoral head isn't underneath the intact dome. And I think in a healthy active patient, I think this to me would be an operative indication.
Yep. Anything you're picking up from the coronals here?
Yeah, I think all these details are important. So again, similar to those transverse fractures, you can see how the cranial lateral head is being loaded by the edge of the intact dome. So similar to the conversation we had on those transverse patterns with these as well, that it's important to make sure that that head is not being worn out by that edge of the acetabulum prior to fixation. So something to keep in mind as well. And then, the area of impaction we can get into as well, a whole big conversation, but how do you reduce that? How do you fix that? And so that's something else you're starting to look at on the CT of how to access and reduce that combination, that impaction.
Yeah, I think maybe outside of the scope of the discussion now about how to access it, but certainly you can get a sense of the impaction of like what is the material you're going to be handling during the case. Is this a nice, healthy block that's going to be able to hold a screw? Or is it like that other case where it's going to be more like a Lay's potato chip? So
And I
here's
would
the,
say on this, Phil, I think for the participants, that may not be intuitive where that piece is and just how posterior it is. So when you see these complex patterns that Steve has here, really take time perioperatively, coronals, sagittals, understanding on the imaging, just where that impaction is, and these are maybe more posterior than you think it is, and then intraoperatively, it may be more posterior than you think just by visualization. So this is a really good case in sort of a 400 level complexity case in terms of where understand the imaging of what's going on and how to address it.
yeah, so on that coronal to that point, here's intact ileum back by the notch and just a few clicks forward and you start seeing the impaction. So it's back there. And this may be where you taking your surface renderings are helpful. If you can ghost them out, seeing, all right, what am I going to be visualizing during the case to judge that I got the impaction right and where is it sitting in the joint? So we've talked a little bit about this. We've classified it. We've talked about approach, anterior-based approach, and some of the reduction strategies. So walk us through this one, Steve.
Yeah, so I think here you can already see just some preliminary flows that are different than the injury x-rays we showed, where now that the head is a bit more underneath that dome, which now you can see the space left for that impaction to come down onto the intact femoral head is much more significant. And so I think all these views give you a sense of the impaction and where it is relative to the dome. And I think, again, just overlying these surface rendered images can be really critical to kind of assess the fracture details and the sequence of fixation. So it shows the anterior column fracture line, which is a nice place to start to get that anterior column back in space where it should be relative to the intact ilium. And this is a clamp application and buttress plating of that anterior column back to the intact ilium, which is just showing that reduction there. And then once that anterior column is reduced, the femoral head is now in an anatomic position relative to the dome, and that gives you the opportunity to then move forward with the impaction reduction back using the femoral head as a template, accessing it through the fracture sometimes. In this case, it was nice to have that potato chip piece of cortex there that we can then peel off and access that impaction I mean, again, we're using fluoroscopy in multiple views to assess that impaction reduction, because oftentimes you can't directly visualize how that impaction is being reduced to the intact head. And then once that impaction was reduced, then we can place some provisional wires and then fill that residual cancellous void with some allograft to really help support the reduction, and then apply some additional implants to fix the posterior column to the anterior column and support that posterior column reduction.
Beautiful case. So that wraps it up. Do we have any other questions from the Q&A that we need to talk about, Steve or Connor?
I didn't see any.
No, I think we'd answered the rest via the chat.
Well, that's excellent. So we appreciate y'all tuning in. Again, one of the goals, both to interpret your radiology, but then take this to the operating room to avoid cases like this one, to be able to look at your preoperative imaging, to pre-op plan, to know what your final construct should look like at the end. So we thank everybody for tuning in. I want to thank Dr. Warner and Dr. Cleveno, especially. Some really amazing cases, some amazing insights, and I appreciate you guys, and had a great time talking through these cases.
Thanks for having us.
Thanks, Phil.